When performing elbow flexion and extension goniometry, we need to look at the position of the humerus in this particular case, and we can see on our patient it looks like she's almost somewhat extended. Because we've got two joint muscles in this case, we've got the biceps brachii, we also have the triceps that are two joint muscles. The range of motion that we measure could be impacted by passive insufficiency. So if she has a tight triceps and she's trying to flex the elbow, she may be limited because in this position, the triceps is already a little bit on a stretch. The same thing goes with the biceps. If she's got tight biceps, we may be limited a little bit in extension. So we do need to put a towel or something underneath the arm so that we make sure that the humerus again is parallel to the floor. Our landmarks are going to be the lateral epicondyle of the humerus as our axis. Our proximal or stationary arm is going to be the midline of the humerus, and the distal or movable arm is going to be the midline of the forearm, and we can also use the radial styloid as our mark. So in this position, and this is another time we don't need to have the goniometer pressed up against the patient. Basically, this is part of the reason why the goniometers are clear, is so that you can see the landmarks. We are using this axis or this going through because her arm is not necessarily in a straight line. And so we're going to be holding it a little bit off to the side. So we're going to ask our patient, bring your hand up to your shoulder. Double check our landmarks here so that we make sure we're midline here, and we are midline here and pointing towards the radial styloid. We have 152 degrees. And then we're going to do passive, which we're not going to get a whole lot more passive here. And we have actually 158 degrees. And then our end field, remember we've got our proximal stationary and then our moving arm. And we're going to give a little overpressure in this case, and normal range of motion for elbow flexion, 140 degrees. The end field could be soft, could be semi-firm. It's going to depend on the body habitus and the amount of muscle that is in between as well. You could have a very soft, but it definitely, because we've got muscle on muscle at this point, is the end field. Now for elbow extension, the other reason that we can have the towels underneath there is because we want to see if there's any hyperextension in the elbow. We can take the same landmarks for this particular position. Now again, I'm kind of hard here, and you can see because of my goniometer is too large here, I could be using a smaller goniometer in this particular case to make sure that I line up properly. I could also ask my patient to move closer to the edge of the table so that I can make sure I'm lined up properly. So my elbow extension, the landmarks are the lateral epicondyle of the humerus, the midline of the humerus, the midline of the forearm pointing towards the radial styloid. And passively, we should not really see a whole lot of difference because now you've got a bone-on-bone end. The same thing goes for your end field. My stationary proximal arm and my distal arm, I want to get close to it. And again, I would be much closer, so I could put some little bit of force in there, take it to the end field. And that should be a hard end field because what you have is the olecranon process is moving into that olecranon fossa, and so we have a bone-on-bone or a hard end field for elbow extension. For our supination, we're going to have the patient in this position. You like to have their arm resting on a table or some other support, so this is going to be our stabilization here. We have to be careful with both supination and pronation that you don't see as they go over that they start to adduct the arm or get some internal or external rotation at the shoulder to get that extra motion into the wrist. So you have to make sure that it stops. And so you want to make sure that they're stabilized properly and you're not getting accessory movements proximally. Because really this motion is truly coming from the elbow more so than the wrist. And you just want to make sure that it's properly stabilized. So we're going to start with the patient in a neutral position, which is the thumb up towards the ceiling. For supination, we also have to make sure we have the right tool for the job. So using our big goniometer like this is not a good idea because it's hard to get in here and to take an accurate measurement. So you either need the smaller ROM goniometer or we can use the half goniometer as well. So our landmarks are on the medial side here, and we're going to be just proximal to the ulnar styloid, even though the ulnar styloid is on the back side. The proximal arm or the stationary arm is going to be perpendicular to the floor, whether it's straight down or straight up. And then the movable arm is going to lie on the inside of the wrist, and you want to avoid the bulky muscles of the wrist here. And so we're going to ask our patient to turn their palm up towards the ceiling. After they do that, you're going to lie the movable arm flat along the wrist. And we have 60 degrees of motion here. And then we're going to do our passive range of motion. She moved her shoulder a little bit there. We have to watch that. We have 65 degrees. And then we're going to do our end feel. And remember, it's not the wrist, so we really don't want to grab the hand and do this big torque through the wrist to get additional supination. This motion is coming up here at the radial ulnar elbow joint up here as well. So we want to make sure we stabilize there, grab the forearm, and take up the slack and do our end feel, which should be a firm end feel. For pronation, now we're going to move the goniometer to the outside of the wrist. And we're going to be in that same position of just proximal to the ulnar styloid. And now we're going to ask the patient to turn their palm to the floor. And we're going to set the goniometer up against the wrist here, lying the movable arm along the, like I said, the least bulky, so over the carpals here in this position. And we have 75 degrees of motion here. And then we're going to do a little passive range of motion and reassess. And we have 82 degrees. And then you're going to come up and with the same stabilization proximally, take up the slack, and with the end feel, which should be a firm end feel. So another way that you can do pronation and supination, because sometimes getting on the inside of the wrist is kind of difficult with the goniometer, is if you have your patient hold something in their hand, and in this example we have them holding a pen. And so now I'm going to take my goniometer in that same position, perpendicular to the floor, either directly up or directly down. And I'm actually going to line up my movable arm with the pen. And so I'm going to ask my patient to bring their hand up towards the palm up towards the ceiling. And I'm going to come back and line up my goniometer. I still have to make sure, remember to go back and make sure that your proximal arm is in the correct position. And I'm going to line up with the hand here, and I have 76 degrees, so this is more than what she had in the other position. If we do pronation, and so ask her to bring their palm down to the floor. Make sure that this is in a direct up and down position, and align the other arm of the goniometer with the pen. And we have 82 degrees in this position. So sometimes it's a little bit easier to have them hold something in their hand and take the measurement from there rather than the inside of the wrist. But you can do it either way, but you still need to do active, passive, and then if possible, the end feel.